Hello, I'm David Badansky, a consultant hand and wrist surgeon, and this is a talk on scaphoid fractures aimed at candidates preparing for the FRCS examination in orthopaedics. I always like this picture of a scaphoid, which is an injection study demonstrating the blood supply into the scaphoid from the radial artery, showing a dominant supply at the waist going towards the proximal pole and a separate blood supply in the tubercle, which illustrates quite nicely why if you have a fracture at the waist or more proximal, you can understand that the blood supply will be compromised and why it will inevitably lead to a risk of avascular necrosis. The reason why we care deeply about scaphoid fractures is because it will lead to a predictable pattern of arthritis. And this is a nice study from colleagues in the Netherlands, which had multiple conversations with a patient, offered them surgery for their scaphoid non-union, who declined, and showed the pattern of arthritis which progressed, but interestingly did not have much in the way of symptomatic arthritis. The reason why this occurs is because when you have a scaphoid non-union or scaphoid ligament injury, you have a altered level or altered pattern of force transmission across the wrist. The first area which gets contacted is the radial styloid, where you start to get pain because you get a wear pattern on the dorsal lip of the radial styloid, and then the wrist will collapse into DZ deformity or dorsal intercalated segment instability, and where the lunate and the capitate which sits in it starts to rock, and now it will start trying to push out the back, and again you get a dorsal lip arthritis. The lunate will then will extend, and in doing so, the articular surface is protected, and you get an osteophyte usually on the dorsal lip, which is why the lunate fossa doesn't get any arthritis until the very end, when you get pan-carpal arthritis. Out of everybody who has a scaphoid non-union or scaphoid lunate ligament injury, they approach almost 100% of arthritis by 10 years. So if you're counselling your patients, you should explain to them the high likelihood of symptomatic arthritis over a 10-year period. Symptomatic wrist pain starts within 1 year of scaphoid fracture non-union, and as the stage of scaphoid non-union advanced collapse progresses, the impact on quality of life and patient evaluation measure, which is a patient-reported outcome measure looking at the hand and wrist, it increases. It's also important to remember that 5% of healed scaphoids can have arthritis, so a healed scaphoid does not always return you back to perfect function. Diagnosing a scaphoid fracture is tricky, and the helpful test at both initial presentation within 72 hours and again within 14 days is to place pressure on the anatomical snuff box with wrist in pronation and ulnar deviation, which is the most sensitive and also specific test you can do. The risk factors for having a scaphoid fracture are having scaphoid pain over the anatomical snuff box with a wrist and ulnar deviation, being male, being young, having a high energy of injury or with the wrist hyperextended. Pain of the scaphoid tubercle is important, and also it is more likely if it is their dominant side. Axial loading of the thumb or telescoping, and also just pain over the anatomical snuff box without ulnar deviation are not helpful discriminators. Men are much more likely to have a scaphoid fracture until the 50s, at which point women start to become more likely. As for imaging, it is typical that initial radiographs taken on presentation within 72 hours are negative and do not show a scaphoid fracture even though one is present. In fact, radiographs miss around 1 in 5 scaphoid fractures that turn out to be later found. And the inter-observer and intra-observer reliability between initial X-rays and those taken as a repeat scaphoid series at day 10 to 14 is only about 33%, meaning bringing a patient back for later X-rays is not a helpful test to undertake for your patients. In comparison, The most helpful tests are cross-sectional imaging, in particular CT and MRI, and in fact MRI is slightly better than CT. NICE guidelines are now moving towards including MRI scan where possible, although I recognise that's not available in all units. So here's an example of a flowchart for you to think about diagnosing and then treating scaphoids. Patient comes in with wrist trauma and tenderness of the scaphoid and non-deviation on the anatomical snuff box. You can get your initial radiographs in 4 views, and if they do show a scaphoid fracture, then that's confirmed. You then want to get further imaging to help quantify it and then evaluate whether it's displaced. The initial SWIFT trial looked at 2 millimeters of displacement, and in other data, which has looked at this again, now reduces this down to 1.6 millimeters of displacement to consider surgery. If it is displaced more than 1.6 or 2 millimeters, you can consider doing a surgery with a screw, and if it's less than this, then you can consider putting them into a cast. If your radiographs do not show a scaphoid fracture, but you still got suspicion, then you can go for a CT scan or an MRI scan where present, and then if there's no fracture, put them into a splint if they're still painful and bring them back to review them again at 2 weeks. Here in the UK, NICE guidelines, or National Institute for Health and Care Excellence, now recommend getting an MRI scan as the first-line imaging for a suspected scaphoid fracture after a clinical examination, rather than radiographs or CT scan. Now we've diagnosed our scaphoid fracture, how can we treat them? We can offer our patients non-operative treatment if the fracture is in the tubercle, if it's in the distal third, where there's a high likelihood of union and healing, if there's an incomplete waist fracture through only one cortex, or if the scaphoid waist fracture is undisplaced, and I think a good cutoff is around less than 1 millimeter. The risks of this approach are non-union of around 12%, initial wrist stiffness for up to 6 weeks, and mean days off work for just over 2 weeks at 15 days. In comparison, you can offer operative treatment with a percutaneous screw or sometimes a plate where necessary if it's an undisplaced proximal pole, because there's a risk of the blood supply to the proximal pole leading to avascular necrosis, and non-union is higher. If there's a displaced fracture visible in radiographs, and a cutoff is more than 1 millimeter, if there's comminution, which would mean this would be an unstable injury, or if it's associated with a perilunate fracture dislocation, and this would be part of the greater arc injury. There are risks with this approach: non-union between 5 and 7%, operative complications of about 30%, and this was shown that even in experienced hands in the SWIFT trial, this was still significant of about 30%, and the mean days off work is about 18 days, so slightly longer than non-operative. For those scaphoids you're going to treat non-operatively, you're going to immobilize them in a below elbow cast and leave the thumb free. Wrist immobilization alone will prevent the scaphoid from moving, and you don't need to put the thumb into a cast, and in fact it's a very debilitating thing to do to patients, and they'll thank you for it. If you cast them in slight wrist extension, they will have a better range of motion when they come out of the cast than if you cast them in true neutral. And 95% of scaphoids treated non-operatively on the criteria we've already given will heal. I get a CT scan at 46 weeks where possible to assess the percentage of cortical bone crossing the fracture site, and the SWIFT trial demonstrates that if you have 20% or more of cortical bone crossing the fracture site at 4 to 6 weeks, it is likely that they will go on to full union. If it is less than 20%, then this is going to not go to a union, and this is an indication for further surgery. And if you have 50% or more cortical bone crossing the fracture site, this is with a screw as strong as a native scaphoid, demonstrated in biomechanical studies, and they can return to full contact sport, which is important if they're a sports person or an elite sports person. Now moving to surgical treatment, you can either approach the scaphoid through the volar approach on the palm side or through the dorsal side. A volar approach is useful to approach the scaphoid waist and gives you the advantage that you can put cortical bone in through the palm side, which is useful to help correct a humpback deformity. A humpback deformity is where the scaphoid has collapsed down from the forces being transmitted across it, and you want to restore the normal architecture of the scaphoid in order to correct that. In addition, the risk of damage to the blood supply is slightly theoretically lower. However, as most of the indications we've given are for the proximal pole, I'm going to discuss the dorsal approach. This is a slightly higher risk of damaging the cartilage or the blood supply, but gives you better access to the proximal pole. For the FRCS Orth exam, I would say with a starved, marked, consented patient on a supine with an arm table with antibiotics given and a tourniquet and x-ray control, I would do a longitudinal incision marked from Lister's tubercle on the back of the wrist, aiming towards the index or third metacarpal. I go through skin, fat, identify the third compartment, which is EPL, open it and move it out of the way, and then do a transverse incision through the capsule, which would take me to the scaphoid-lunate ligament and also the scaphoid and also the lunate. Technical tips for this are if you put the wrist over a bolster, it will give you better access, and also if when you want to put a K-wire in to aim for your trajectory for your screw for percutaneous or mini-open fixation, as you can see here on the right-hand image, the ideal start point is just where the scaphoid-lunate ligament inserts into the scaphoid. So just go a little bit radial from that into the scaphoid, and if you aim towards the tip, if you straighten the thumb and aim straight down the thumb with your K-wire, that will take you down the trajectory of the scaphoid very nicely. Your options for surgery are K-wires. The advantage is that these are solid and they're easier to take out, but they don't give you any compression. The newer technique, originally described by Nick Goddard, is to put a compression screw across the fracture site. Key points on this are to improve your likelihood of fixation in biomechanical studies are putting the screw perpendicular to the fracture. A central screw placement gives greater stiffness and load to failure, and also a longer screw, by which I mean if you can go from cortex to cortex. I always visually identify where my tip of the screw is going to make sure that it's buried underneath the cartilage, because on post-operative radiographs you'll always see, and it always worries you, that the screw looks slightly long and it's sticking out of the scaphoid, but it's not, because there's about 1 or 2 millimeters of cartilage on both ends. And also there's an option to use a plate, which is useful for scaphoid waist fractures where you've had a previous problem with screws that have failed, or you have a large humpback deformity and you want to put a corticocancellous bone graft in and stop it from being extruded. Tips, just to reiterate that, are to aim down the thumb with a K-wire, to aim starting from the insertion of the scaphoid-lunate ligament on the scaphoid, and I always put them over a bolster or scaphoid roll to help you get that trajectory. I also like, when using the dorsal side, a slightly stiffer wire, and Synthes, which is one company for their CCHS, gives a cobalt chromium wire which is at less risk of bending. There are many other companies available. This is an example of an acute scaphoid fracture of a 26-year-old junior doctor, now resident doctor in the UK, who otherwise fit in well. He was playing in goal around 5 to 6 weeks ago and caught a ball and then fell onto his hyperextended right dominant wrist. Here are some radiographs on the left and the middle that show he's got a scaphoid proximal pole injury, and you can already see some early cyst formation in the CT coronal view on the right hand side. So for that, I offered him the pros and cons of time in a cast versus surgical fixation, and I also offered him a bone graft at the same time in order to fill the cyst, which is already starting to develop. These are radiographs taken 2 weeks post the dorsal screw and also the distal radius bone graft. When it comes to bone graft, you can either take, I prefer to take autograft, and you can either take from the distal radius or from the olecranon or from the iliac crest. Many people say that the quality of bone graft for taken from the iliac crest is better, and also gives you, when necessary, a ability to do a corticocancellous bone graft, which will hold open a humpback deformity. Very useful if you have a humpback deformity in a waist fracture and you're approaching from the palmar side. This is on the back of the wrist, and this was a contained defect, meaning that when I opened it, the bottom and sides of the defect, the cavity, were intact, so it just needed to be freshened and packed. Therefore, I go for the distal radius because it's on the same site. You don't need to prep the same area. And also, there are theories that if you irritate the medullary canal of a bone segment, it'll increase blood flow to that entire upper or lower extremity and help with union. And this is a CT scan that I take at 6 weeks to see whether he's got union. Just to reiterate, if you've got 20% or more, then it's going to go through to union. And if you have 50% or more plus a screw, then biomechanically it's as strong as a native scaphoid, and you can go back to contact sports. Here's the scaphoid screw crossing with 90% union. You can see the tip of the screw. It looks like it's sticking out, but it's not, because I've taken a very careful visual inspection to make sure it's indeed buried. And you can see the distal radius donor site, and he's been in the cast for 6 weeks. And that shows that he's got good union and he could go return to all activities without any restrictions. So, choosing between a surgery and a cast. The SWIFT trial, which is surgery versus cast immobilization for adults with a bicortical fracture of the scaphoid waist, was looking at skeletal adults presenting within 2 weeks of injury, and the bicortical fracture was defined as a break in both cortex and cortices on any radiograph, and the displaced fracture was set at 2 millimeters or more of the scaphoid series. They had a lot of patients, and those that had surgery were defined as those that went for percutaneous or open surgery at the surgeon's preference. They used headless compression screws or whatever type the surgeon was using, and they said that the surgeon could do their typical practice for implant, surgical approach of palmar or dorsal, and post-operative care. And if they were going to have cast immobilization, they would have it for 6 to 10 weeks with or without thumb inclusion, and if they had immediate fixation, if they had a non-union that was confirmed. So the base line characteristics were very similar between the surgical and non-surgical cast groups, apart from smoking, where there was slightly more within surgery and compared to those treated in a cast. And the patient-reported outcome measure of choice was the PRWE, or patient-rated risk evaluation. Those that had surgery had it around 10 days post-injury, and those that had a cast wore it for 44 days. And 90 out of 214 had a splint for a further 26 days. So this is an important point. There was no difference in patient-reported risk evaluation up to 52 weeks after the initial treatment, although you can see that surgery did slightly better initially. And there was slightly more union in the surgical group, but this was not significant. So here are the key messages. Patients with a bicortical scaphoid waist fracture displaced 2 millimeters or less have little difference in pain or function if treated in a cast compared to surgery. Non-unions requiring surgery, which is defined as 0 to 20% union on CT, was not significant for both treatment arms. And as adjusted odds ratio, this was for surgery 4 out of 219, and for casts 9 out of 219. At 6 and 12 weeks, cast patients have little more pain and worse function compared to surgery, and there's little difference in lost days of employment. So telling your patients you'll get back to work sooner if you have surgery is probably not accurate. So here are your take-home messages for the FRCS examination. If you have a scaphoid fracture, which is of the distal pole or the scaphoid tubercle, or of the scaphoid waist, which is less than 2 millimeters displaced, it can be treated successfully in a below elbow cast for around 6 weeks. The cast will be in wrist slight extension and doesn't include the thumb. If, however, it is of the proximal pole, there's comminution or an associated injury, or it's displaced, you may need to think about surgical fixation, or if there's a non-union identified on CT in the expected healing period. If the radiographs suggest concern about bone union, get a CT scan to confirm non or slight union, which is less than 20% of cortical crossing at the fracture site. And in conclusion, proximal poles need surgery, distal poles need cast, and in between there's discussion depending on the amount of displacement. And MRI is now much more useful for diagnosis, and that's what I go to. If you'd like these slides, here's a QR code for you, and I wish you the best of luck. Thank you.